Welcome, everyone, to today's Explainer. If you're prepping for clinical exams or just really want to lock down the absolute fundamentals of nursing procedures, you are in the exact right spot. Today, we're diving into a heavily tested clinical blueprint, urinary catheterization. We're going to take all those dense, dry textbook pages and basically translate them into clear, actionable takeaways. So, let's get right into it. Okay, really quickly, here's our roadmap for today. We'll be hitting 1. The basics and purpose. 2. Catheter sizes and parts. 3. The different types of catheters. 4. The step-by-step insertion procedure. And 5. We'll wrap up with complications and the golden rules of care. All right, kicking things off with Section 1, Basics and Purpose. So at its core, what are we actually doing here? Simply put, when a patient physically cannot pass urine normally, we step in. We introduce a flexible, kind of rubbery-like tube to do the heavy lifting for them. Now, usually this goes right through the urethra, but sometimes it's done suprapubically, which basically means going directly through the abdomen right into the bladder. But why do we do it? Well, it goes way beyond just draining urine for a blockage, like, say, an enlarged prostate. This is actually a vital diagnostic tool. Think about it. If you've got a critically ill patient in shock, or maybe someone with severe chronic kidney disease, you can't just guess their fluid balance. You need precise, down-to-the-milliliter accurate urine output monitoring. We also use this procedure to grab perfectly sterile urine samples, and even to flush the bladder out or instill medications directly during surgical recovery. Moving right along to Section 2, Catheter Sizes and Parts.
Okay, sizing. It's all about the French scale. You're going to see catheters labeled with an FR number. To kind of picture this in your head, roughly 3 French units equal just 1 single millimeter in diameter. So think about the thickness of a credit card.
Now, please don't get tripped up here. Unlike IV cannulas, where a larger gauge number actually means a smaller needle, the French scale is totally straightforward. A larger number directly means a larger, thicker tube. For pediatrics, we're looking at smaller sizes, like 6 to 10 French, usually color-coded green, blue, or black. Adult females typically need a 12 to 14 French, while adult males usually take a 14 to 16 French, which is often marked with a bright orange port. And if you're doing something like bladder irrigation to clear out blood clots, you'll need a massive 22 or 24 French tube just to make sure nothing gets stuck. Let's break down the physical anatomy. You've got the firm tip up front for smooth insertion. Right behind that is a small inflatable balloon. And listen, this is a massive exam point. We never, ever inflate that anchoring balloon with air. Why? Well, unlike a breathing tube in the lungs where air is harmless, if a catheter balloon pops inside the bladder, air can cause real trauma. So strictly use 10 cc's of sterile water or normal saline. After that, you've got your drainage port, your color-coded balloon inflation port, and sometimes a third optional port just for flushing the bladder.
All right, Section 3. Let's look at the different types of catheters.
So you've basically got 2 main players here with very distinct clinical roles. Intermittent catheters are your quick in-and-out solution. They're just simple, straight tubes, no balloons. Picture a patient recovering from spinal anesthesia who literally just needs temporary help emptying their bladder one time. Indwelling catheters, though, the ones we call Foleys, they're built for the long haul. They stay inside for days, safely locked in place by that inflated balloon we just talked about. We also have a couple of specialized tools. The suprapubic catheter bypasses the urethra entirely, entering straight through the abdominal wall. Examiners absolutely love this detail. The suprapubic route is actually considered the gold standard for gathering a perfectly sterile urine sample. Then you have the condom catheter, which is completely non-invasive. It's an external sheath used exclusively for males. Really perfect for managing continuous incontinence without exposing the patient to the infection risks of an internal tube. Which brings us to Section 4. The actual insertion procedure. You've got to memorize these subtle prep differences because tests will definitely try to catch you on them. For a male patient, they're positioned supine, legs just slightly apart, and you clean the area in a circular motion. Simple enough. But for a female patient, they need to be supine with knees flexed, and the cleaning must strictly happen from front to back. Obviously, that's absolutely crucial to avoid dragging bacteria into the urinary tract. Anatomy also dictates the insertion depth, right? Males have a much longer urethra, so you're looking at inserting about 6 to 9 inches, that's roughly 15 to 22 centimeters. Females require significantly less depth. You only need to go in about 2 to 3 inches, or roughly 5 to 7.5 centimeters.
So how does this all come together? This is what we call the golden insertion sequence. You prep with sterile gloves, you cleanse, and you heavily lubricate the tube, usually with xylocaine. Then you insert to that gender-specific depth we literally just covered. But here is the major hidden trick in step 4. Seeing urine flow only means the very tip is inside. You have to push it another 1 to 2 inches further. Actually, let me emphasize that. If you don't push it further, that anchoring balloon might still be sitting in the narrow urethra when you inflate it. That will cause severe trauma. So push it that extra inch or 2, and only then do you inflate the balloon with sterile water. Finally, let's wrap up with section 5, complications and the golden rules. Listen, if you take nothing else away from this explainer, remember this fact. The humble urinary tract infection, the UTI, is literally the single most common hospital-acquired infection overall, and it is directly linked to this exact procedure. That's exactly why your technique has to be absolutely flawless. Alongside UTIs, we're always on the lookout for urethral trauma, bladder spasms, and hematuria, which is just blood in the urine. But I really want you to focus on the contraindications. When do we hit the brakes? If a patient comes into the ER with a pelvic fracture, or if you suspect known urethral trauma, severe strictures, or they've just had recent urethral surgery, you stop. You never ever insert a catheter blindly in these cases. Hitting pause and consulting a doctor first is your absolute top responsibility here. I've seen so many students get tricked by this concept, so please burn this into your memory. Because suctioning a patient's airway looks so intense, people always guess it's a sterile procedure. It's not. It's considered a clean procedure. Catheterization, on the other hand, deals with the highly vulnerable, completely sterile bladder. It requires uncompromising, strictly aseptic, sterile technique from start to finish. No exceptions. To keep your patients safe day to day, follow these golden rules. Maintaining the drainage bag below the bladder level is pure physics, right? Gravity is your absolute best friend when it comes to preventing dirty urine from flowing backward into that sterile bladder. But make sure that bag never touches the floor or sits on the bed. You've got to perform dedicated catheter care at least once per shift. And honestly, the best thing you can do, advocate to remove that catheter as soon as it's medically safe to do so. The faster it comes out, the faster that infection risk plummets. Oh, and one last thing, never clamp a catheter without a direct medical order. So, as we wrap up today's explainer, I want to leave you with a thought. Knowing what you know now, that UTIs are the top hospital-acquired infection and that just one tiny slip in aseptic technique can cause severe harm to a patient, how are you going to champion these golden rules? How will you protect your future patients when you're under the immense, real-world pressure of a busy clinical shift? It's a pretty heavy responsibility, but with the structured knowledge we just went over, you are absolutely ready for it. Thanks so much for hanging out and learning with me today. Keep that curiosity focused, and I'll catch you in the next one.